with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Okay. Good evening, I'm Gregory Leach. I'm here again with my co-host Jim York with Dialogue with a Doctor. And this evening we're welcoming Dr. Arturo Balandra. He's a urologist from Naples Urological Associates, and he's here to talk about female incontinence.
Absolutely.
And first we would like some information about your background, where
Sure.
you come from. How did you come to be here?
Yeah, so well, I guess going way back in time, I was born in Mexico. And then I moved here when I was 12 years old. I moved to Miami with my family, which my family is in Miami, and that's why we kind of settled here in Naples, close by to the grandparents from my son. But then after that, I went away. After doing high school in Miami, I went away to do all my training and university in not in Miami. I started off going to Vanderbilt in Nashville, Tennessee. And then I went over to the University of Pennsylvania in Philadelphia. That's where I did my medical school training, as well as all my urologic training. I decided to stay there because they have a great program. There's a great, my mentor there is a very well-known and very wise urologist, so I stayed in that area. And then finally, when we had our son, we figured we should come home close to home. So, the grandparents are happy because they're in Miami and they can just cross the Alligator Alley and be here with the grandson. So we're happy. We're starting a practice here. So,
Doctor, tell us a little bit about your practice and your locations. And
well, I came in. I joined with the Naples Urology Associates. So the associates part is Dr. Spellberg, who's been here for a long time, and there's also a new doctor called Dr. Gutman, who's down in South Naples. But my locations are: I have an office at Physicians Regional in Pine Ridge. We rent it from them, but we see patients in both hospital systems, Physicians Regional and NCH. And my other office is in Bonita. So I'm about half the time in Pine Ridge and 75 and half the time in Bonita. The office in Bonita is just across from the Promenade. It's a mall there. It's about a mile north of Bonita Springs, Bonita Beach Road. And, that's where I'm at. The practice basically is general urology. So I see all sorts of patients. That's why I went into urology, because of the breadth of disease processes that we see and problems for people, including both female problems, male problems, cancers. So I really have a like for general urology as a whole. We have a doctor in our practice as well that does a lot of robotics. So that's kind of one of the things that we do for cancer. So it's a broad practice for a broad number of problems.
if someone wants to see a doctor, do they have to have a referral, or can they call your office?
No, they can call my office straight away. The number I think will be on the screen at some point. And they can help them out with making the appointment, the timing of the appointment, as well as whatever insurance needs they have, or to be able to figure it out. But no, we welcome everybody.
Okay.
So.
Your two different locations.
Mm-hmm.
You do the same thing in both locations, or
yeah,
do you segregate?
Absolutely. No, I see all the problems at both locations. It's really more a geographical availability for patients that live. I don't want to make them go somewhere. So that's why we have both offices. So people that live in North and Bonita, they want to stay locally, we can go there. Obviously, urologists in the end are also surgeons. So when I have to do surgery on a patient, we do it. Also, I have privileges in all the hospitals. So wherever the patient's closest to, I'm happy to do the procedure, or in a surgical center.
Well, we're going to take a short break, and after the break, we'll be back to talk with Dr. Balandra more about urology and female incontinence.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together, was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
The survival rate from early caught breast cancer is about 97%. Mammography survives by detecting that breast cancer early.
Radiology Regional Center, earning your trust yesterday, today, and tomorrow.
Radiology Regional Center is happy to bring you digital mammography. The advantages include shorter exam time, fewer retakes, and lower dose radiation. Radiology Regional Center, the best just got better.
Welcome back to Dialogue with the Doctor. Once again, we're here with Dr. Balandra. We're talking about female incontinence this evening. And Jim, I think you had a question.
Doctor, why don't you just start off with us then on the subject of female incontinence?
Sure.
Maybe age-wise, or who has these problems,
Sure.
If it's a medical history or inherited, or
Sure, absolutely.
weight-wise.
Well, yeah, that's common too. So, continence in the most basic form is being able to just pee when you want to pee, meaning which is really when you're standing in front of the bathroom. So, incontinence is anybody that has problems where when they're not standing in the bathroom and they want to pee, they leak. And it could range from a couple of drops that you have to wear a pad from to being completely incontinent where you have to wear a diaper or some sort of collection device. It actually can affect people of all ages. Obviously, the younger you get, you have problems that are more inherently developmental or that came, from genetic problems or from early on medical problems. But more commonly, what we see is people in their older ages, and in this topic with female incontinence, usually older women, sometimes past menopause, with sometimes history of having, being mothers, because as we will talk later on, that can affect your incontinence as well. And the causes can be very varied, and it's kind of a interesting patient to see because you really have to get at what exactly their problem is and what the root of the problem is, so we can come up with an appropriate treatment for them. But yeah, the presentation is usually older women with problems of having to wear a pad, as basic as that.
Why does this happen to older women or women in general?
So the way we, I'll say we, but really the way we hold on to our urine is partly through the muscles in our pelvis. You can imagine when you're urinating, all the activity is down there, right? That you would put in quotes down there. And those are muscles, right? And just like any other muscles, as we get older, we get a little weaker. And those muscles can get weak too.
Do they stretch?
They stretch as well, obviously. And the reason, just as you can imagine, when evolutionarily we went from walking on all fours to standing up, all the pressure, all our bowels, all the things we eat, all the weight we have inside our body is rested on this pelvis, right, which is kind of like a calyx. I mean, it's sort of like a cup that all our organs rest there. So as the years go by, that's pressure that's being put on those muscles. And as the muscles get weaker, that pressure can change the way those muscles work and can cause some problems with continence. And in women specifically, because women have the birth canal, which is where we all came from, whereas men don't have that. So men have a point in their body where the birth canal is in women, where you have more support. You have more a way to pivot all those muscles and support all those muscles, whereas women, being that they have that canal, it's another orifice in their body that is not supported. So that's why through the years you can have some weakness of that, leading to some problems with incontinence, at least in part.
How do you correct the problem if somebody comes to you, or how do they know they have it? If it's just sporadic once in a while, or is it a constant problem? When do they?
I think that the most important thing that I tell my patients when they see me, when they have a concern, they usually come because it's affecting their lifestyle. So, some people, maybe grandma, we might know grandma has a pad and wears a pad and she knows it and she's not worried about it. And if that's the case, if it doesn't affect her, it's not necessarily something we need to fix, because for her it's socially acceptable if it's to a low degree that she's not bothered by it and she can get through the day without it, then that's okay. Usually when I see patients, it's because they're bothered by it. They want to try to find a way to fix it. And then, before talking about fix it, just like when you go to any physician, we try to figure out, well, why did it come from in the first place? And that becomes a whole, office visit, things that we do and the diagnostic tests that we have. And I can talk about those a little bit if you guys want.
Great. Well, you said I believe there are two types of incontinence, stress and urge.
Yeah.
What are the difference between those two?
Yeah, and that's, when you come and see me in the visit, one of the first things I do is just talk to you for a little bit and figure out, where the problem is. And we can usually categorize incontinence or leaking in two different areas. So one is stress urinary incontinence. And what that is people will complain that when they're coughing, when they strain, they have a little bit of leak. When they get up from the seated position to being standing up, they have a leak. When they're playing tennis and they do their golf swing, they leak. And that's basically when they're stressing their abdominal muscles. So what that means is, you put a little stress there, you bear down, and then the pelvic muscles, which as we talked about, could be a little weak, then you have the leakage. So that's stress urinary incontinence. Then you have urge incontinence. And urge incontinence comes from urge. And the way we define urge is basically the sensation that you have to urinate where you're afraid that you won't be able to make it to the bathroom. And some of those times, you actually don't make it to the bathroom, and that's where urge incontinence comes from. So those complaints, the patients come in saying, well, all of a sudden I was watching TV, and out of the blues I had to go to the bathroom, and I had to run to the bathroom where I was going to pee. And that's usually the complaint that you get from that type of incontinence. The reason we try to divide it is because sometimes the etiologist or the anatomic reason or the pathologic reason why these two things are going on are different, and hence the treatment would be different down the line.
So what is going on that's different?
Yeah. So with stress urinary incontinence, usually, as you can imagine, it's more of a physical thing. It's more of a physics thing in the sense that you're putting pressure somewhere and the pressure has to be relieved somewhere else, which means that why did it happen all of a sudden? When I was in my 20s, I could put pressure all I wanted in my belly and I wouldn't leak. So if we were talking about the fact that the muscles got weaker, that's where stress urinary comes from. Stress incontinence comes from weakness of the anatomy, weakness of that pelvic floor. We used to make an analogy as to, if you have a gardener spraying with the hose, the plants, and they
Right.
want to stop that flow, they could step on the hose, concrete floor, and you would stop the flow because you're putting pressure on the concrete floor. The concrete floor in this case is the pelvic floor. So that if you're doing the same thing, but you're in the grass or you're in a soft area, and you put your foot on the ground on the hose to try to stop the flow, well, the grass is going to give and the flow is not going to stop.
Right.
So in a similar manner, when you're young, your muscles are strong, like concrete. So when you put pressure on them from your belly, the flow will stop. As we get older, those muscles get softer, so when you put pressure on them, it's like the ground. They give up a little bit, and hence the flow doesn't stop. So that's kind of the idea behind stress urinary incontinence. It's a weakness of those muscles. It's a change in the anatomy of those muscles that prevents us from being able to hold on to that urine.
Question is, you're going to go into how to treat this.
Sure.
But what I'd like to know is how did people treat it 20 years ago compared to what they're treating it today?
Yeah, well, and that's a good question. Going down the line of the stress incontinence, which is what we just made that analogy to, in the past, we would make kind of big operations to try to fix this problem. And the operations would be to try to get the muscles and the anatomy and the architecture back to what it was before there was weakness. So, again, going to the analogy of the pelvic muscles and the abdominal organs kind of falling out of the body because of this weakness, what we would do is we would make an incision in your belly, pretty big incision, and then we would kind of pull the vagina and the uterus and all that stuff forward, backwards, and put stitches into your bones to try to keep that in place so that the anatomy was there to, again, make your floor stronger so you could stop your urination. That's how we used to treat them, and sometimes in certain cases we still do that kind of procedure. We have cooler toys now, so they're smaller incisions and less invasive things. But in the basis, sometimes that still happens. The newer things is that we artificially create support for your body by using mesh, which is an artificial material that we put there to bolster your pelvic floor. And we also have some medications that we can give you that are newer, that weren't there in the past, but that's more for the urge incontinence part that we haven't really touched.
Before you do that, you bring a patient to the office, of course, and what will a patient expect for kind of a workup for this?
Sure. Yeah, I mean, the most important thing is number one, the history. And because it's so important, actually, when I see a patient that has incontinence, on their first visit, I take a good history, I see where they're bothered, how long it's been since this has been developing. And then I also do a physical exam. In the physical exam, I can tell if there is weakness, where there is weakness. Is it in the sort of anterior part of the pelvis or the posterior part of the pelvis? If there is any actually big abnormalities, such as the bladder dropping out, that you hear some people, my bladder fell out. It doesn't actually fall out, but it's kind of, coming out of their vagina. And those things also tell me a little bit about how different their architecture is from what it was before, from what it should be. But then, because again, the history tells me so much, I send them home and I give them a voiding diary, which is basically just a piece of paper where they're going to write for me how many times a day they're actually leaking, what were they doing when they were leaking, and how many times they have the sensation that they have to go to the bathroom or they're going to pee, to really get a great idea as to what exactly is going on with that particular patient. Because the pelvis and the act of voiding is such a complex entity, which has nerves and muscles and architecture and physics principles, that we really need to know exactly what's going on before we go forward with treatment. So they should expect a physical exam, a history, and then going home with a little diary for them to fill out and then come back and see me.
Then what happens?
Well, then we have a little bit more. Then we have a little bit more to go on. And depending on what kind of tree they fall on, is it distress incontinence, or urgent incontinence? Of course, there's also mixed people that have both problems. We may do some other tests. People with urgent incontinence, in the end, we have something called Urodynamics, which some people might have undergone. And that's a test where it's a little invasive. We actually have to put some tubes into the bladder, and we measure really the pressures and the architecture of how things are working as people are urinating. So it's really an online, on-time test to figure out what's going on as people are urinating and as people are leaking. And it really gives us a lot of details. But it's not for everybody. Not everybody needs a urodynamic test. We can tell a lot from their history and from their exam to be able to treat them.
So I've heard of women doing exercises for this. Are they used in just the more mild cases?
Well, yeah, it's a great question, because it's definitely something that has been going on for many years, the whole 20 years, and now we have something called biofeedback, and that's true, that's in many fields we have that. And all it is, it's exercises that are aided by some visual tests. So sometimes we hook up little electrodes to patients' pelvic muscles, and they can see as they are exercising them, a visual graph of how much they're exercising them. And we know that from research that it helps people focus on those muscles. Now, usually, and I think from our experience, most of the times when people do exercises, it will help them overall, but it won't cure or it won't stop people from leaking that have a lot of leakage. So yes, it's for people that have a milder problem. But that being said, because incontinence tends to be a quality of life issue and a personal issue as to how much I am willing to tolerate of incontinence, maybe those people with severe incontinence, after doing exercises, will be to a point where they're happy enough when they can go through dinner without having to wear a pad or change their pad. So we always try the exercises in cases when it's a stress incontinence issue, because you don't know, maybe by doing the least invasive thing, which is a personal exercise program, you might end up being in a spot where you don't need any further treatment. But in reality, the more severe cases do need a little bit more help from us.
Does overweight have anything to do with this,
Yeah,
or your diet or anything like that? Or?
That's a great question. Actually, the diet doesn't really seem to have anything to do with, at least with stress incontinence.
Mm-hmm.
Sometimes with urge incontinence, there are certain things that can irritate your bladder, that can worsen the symptoms.
Caffeine or whatever?
Caffeine is one of them.
Mm-hmm.
For some reason, tomato products is another one. But we again, people that come to us sometimes, for the most part, are older people. They have their way set. They've been drinking their coffee, their tea, their tomato juice, their pizza. So we do, even though it can help them decrease the episodes, we first try to figure out if there's something else we can do for them. Because again, it's a quality of life thing. So I want to keep their quality of life going, and I don't want to tell them don't eat this, don't eat that at that point. But it's something we can try. Now, the weight issue is definitely important. The weight issue, we know that people that are overweight, and we measure that by their body mass index that people may know about, do have a higher incidence of having incontinence problems than people that are not. Is it because of overall strength and exercise? We don't know. It could also be just from weight, of their muscles and of their internal organs, because we know from experience, just because we've done surgery, that people that are overweight are not only overweight outside, but they have fat inside their bodies, next to their bowels, and that stuff is putting pressure again on that pelvis. So that's a potential reason as to why they may have increased incidence of it. So losing weight is always a great idea.
Well, today we have a higher proportion of people that are very interested in health and that are exercising even as we age.
Right.
So is there any, or has there been observed any difference between those people that are extremely physically fit, even though they're 60, versus somebody who is not physically fit? Is there a difference between those two people?
Yeah, you know what? I don't have an answer for that. But that's a very good question. Because you're right. Nowadays, for the last, 15, 20 years, people have a high awareness of being healthy and being good. And I don't know, I don't think we've done the studies to find the answer to that question.
Well, obesity it's clear.
Right.
But
those, exactly, the people that are older and more fit, you would imagine and you would hope that they would have less problems with incontinence.
So how do you fix it?
So fixing it, in the end, urologists are surgeons. We're office doctors as well, which is a nice thing. So when it becomes becomes an issue that is not being fixed by exercises or by dietary control, depending on where we are, if it's a stress urinary incontinence problem, we do have surgeries that can help with that. And it's basically, as we mentioned, putting some mesh. We take you to the operating room, and we put an extra support in the area where the pelvis is. So again, we're creating that hammock, that backboard, so that when you're urinating and you put pressure to hold your urine, you have something to actually put pressure behind and have decreased chance of leaking. In the other area, which is the urge incontinence part, we do have a lot of medications. A lot of the pharma drugs have come out with anticholinergic medications. Patients on TV might have heard this. It's basically Ditropan or oxybutynin or Vesicare. They advertise on TV. But the point, what that does, it's a medication that blocks the nerve activity to the bladder that tells the bladder that it needs to go. So that it only goes when you're standing in front of the bathroom, concentrating and telling it, okay, it's time to urinate. And in between, when you're at dinner, when you're watching TV or being in the movies or in a restaurant, your bladder won't do that on its own. So it helps with that urge and urge incontinence. So for urge incontinence, the treatment starts with medication. And it's sometimes tougher to treat in the end because the people where the medication doesn't work, it's not an architectural problem that we can fix. It's more of a nerve problem and a muscle problem. And as people know, those are harder to treat than kind of things that are broken that we put back together. There is some other things down the line for urge incontinence that we're treating, that we're using, that we can talk about later, and that may work.
The surgery, is it invasive, or is it what's the recovery time, and what is the success rate?
So for the stress incontinence part, which is that mesh surgery, or actually we don't have to use mesh, we can just use sutures and things to put things back together. It's actually a very minimally invasive surgery, in the sense that particularly in women, we obviously use we go through their vagina. So it's an orifice that's already there, so we don't have to make a big incision anywhere in their belly. And in their vagina, we're able to make a little incision and then put that sling using very small needles, and patient goes home the same day. They take it easy for a couple of days to make sure things heal nicely, but then they're able to do more of their activity. So that's a very quick and little invasive procedure. Of course, all surgery there's risks and invasiveness, but as it goes for surgery, it's a quick procedure.
Success rate?
So the success rate with stress depends a lot on the anatomy and what we're fixing on the patients. But on the well-picked patient that has not a lot of kind of drop, that their anatomy is not completely out of whack, we usually quote them at least a 60% chance of being dry from having a pad. But that varies a lot because one person uses one pad, the other one uses 3 pads, the other one uses a diaper. So there's a big range of patients that they come to see us. So the outcome, of course, is going to be varied as well. For the other side, for the urgent continence part, the last thing we use is what we call a pacemaker for the bladder. And that's the same company that makes the pacemakers for the heart. They make these stimulators that we can put in the nerves of the bladder, since we talked about the urgency and the urgent continence part being more of a nerve and muscle problem rather than an architecture problem. We use this nerve stimulator that we placed, and it seems to help a lot the people who's in cases where the medication doesn't work. So it quiets down the bladder so that, again, you're only urinating and going to the bathroom when you want to, when you're in the toilet, not when you're walking around in the mall.
So there's been some talk about some mesh failures, a recall, and my patients have asked me about that.
Yeah, it's something, it's been on the news, and again, it's been on TV. If you've ever had mesh, call me, etc.
1-800.
1-800, call me for the mesh. And what that is, it's one of those things where mesh has more complications than not using mesh, in the sense that if we use mesh to put your pelvis back together, you can have some complications such as the mesh extruding, which means all of a sudden you can see the mesh in your vagina, and we need to fix it, right? If we don't use mesh, those problems aren't there because, again, the mesh isn't there to cause that. But what we tell our patients is if we use mesh, the chances of you having a recurrence of your problem is much, much less. In other words, our reoperation rate in 10 years is very little. If we don't use mesh, the reoperation rate, maybe in 5 years we'll have to go back in, or in 3 years we'll have to go back in. So if we have a conversation with the patient and we tell them, the side effects and the possibilities, then we make a decision together to figure out, should we use it, should we not, what are we comfortable with? But it's definitely something that is FDA approved, and it's something that we can use.
How is it easy for a patient to get to see you?
Absolutely. They can just call the number, and I'm happy to see them, sometimes even the same day if I'm available, but definitely. Absolutely.
Well, thanks for coming. I think we learned a lot about female incontinence.
Hope you come back again.
My pleasure, absolutely.
I think it will help our patients.
Great.
So, thank you for being here, and come back and visit us again next time.
Sit here and talk.